Hello, my name is Dr. Dewan S. Raja. Today I will go through the visual pathways, optic pathways, and also will go through some of the visual field defects. So, what are the components of visual pathway? It begins from the retina. Retina is the inner layer of the eyeball. This is the nervous layer of the eyeball. We have the outer layer, that is the fibrous. It is composed of cornea and the sclera. Then we have the choroid layer, and the inner layer is the nervous layer, that is the retina. From there we'll get the optic nerve. This is the optic nerve. Optic nerve. Then this is here. This is the optic chiasm. What happened? We have the nasal fiber will go to the other side. The temporal fibers will not cross. It will go to the same side. This is the optic chiasm here, also sometimes called optic chiasma. From there we'll get the optic tract. Optic tract is going to the lateral geniculate body. So this is the lateral geniculate body. Lateral geniculate body is a part of the thalamus. Okay, lateral geniculate body has 6 layers, and for the ipsilateral side, same side, we'll get for the lateral geniculate body 2, 3, 6 layer. Okay, and for the contralateral fibers, the lateral geniculate body has the 1, 4, 6, first, fourth, and sixth layer. So these are the arrangement of the fibers of the optic tract in the lateral geniculate body. So one is the 236, second layer, third layer, sixth layer, that is the ipsilateral. Contralateral is 1, 4, 6, first, fourth, and sixth layer. So from the lateral geniculate body, and this is a part of the thalamus, will get the optic radiation, also called geniculocalcarine tract, that goes to the occipital lobe to the calcarine sulcus, to the area number 17. Okay, so that is the visual cortex, also called occipital cortex. Okay, if you go there, what are the common visual field defects? We have central scotoma, that may be some part of the the vision seems to be dark, or there's some blind spots. Okay, that is central scotoma. It may be also circumferential scotoma. Total blindness will get that. Entire nerve is cut. Entire optic nerve is cut. Bitemporal hemianopia, that is due to a lesion of the optic chiasm, usually by the pituitary adenoma or pituitary tumor, that actually cut the the crossing fiber at the optic chiasma. We have the nasal anopia. If this happens, if the lateral fibers of the optic nerve is cut, the lateral fiber, the temporal hemiretina actually represents the nasal field of vision. We'll get the nasal anopia. We'll get homonymous hemianopia, that may happen if the optic tract is cut. Okay, so right optic tract is cut, then the left side vision will be lost. We'll go there. Then homonymous superior quadrantonopia. This may happen especially after the lateral geniculate body. The fiber will be divided into upper fiber, lower fiber. The lower fiber that goes in relationship to that of the lateral ventricle of the brain, that goes through the temporal lobe of the brain to the occipital cortex. So any lesion there will get the homonymous superior quadrantanopia. Like that, we'll get also homonymous inferior quadrantanopia. This may happen when the optic radiation fiber goes through the parietal lobe, the upper fibers, if it is damaged. Homonymous hemanopia with macular sparing, that is possible. Usually this is close to the occipital cortex area, and the macular area of the neuron are spared in this type of lesion. So these are the common visual field defects is found in the visual pathway. Okay, we got that. Let's try here. So we'll get term scotoma. Scotoma means Greek, it means spot, is a defect in the visual field surrounded by normal vision or less defective vision. Okay, scotoma may be caused by a lesion within the retina or the optic nerve. Other causes are stroke and tumor along the visual pathway. Okay, maybe caused by a stroke like cerebrovascular accident or any tumor along the visual pathway. It is perceived as an area within the field of vision where the patient sees dark. Okay, the patient sees dark. Okay, we got that. So here we have the visual field defect. Will compare normal and abnormal here. Okay, the left eye, right eye. Actually, I have plotted this spot to indicate the central scotoma like this, where it is not in this image. This image was without any spot. I put the spot to show the central scotoma. So let's start one by one. Suppose this entire nerve is cut, what will happen? So this is the right optic nerve is cut. What will happen to in that situation? Then we'll have a total right eye blindness due to section in the right optic nerve. Okay, this is the optic chiasm. If it is cut, what we'll get? We'll get bitemporal hemianopia. So the lateral vision, field of vision will be lost. That means the temporal field of vision is lost. Idea is that the the these are the nasal fiber. This nasal fiber, this is the nasal hemiretina that represents the temporal field of vision. Okay, and the temporal hemiretina represents the nasal field of vision. This is due to the presence of crystalline lens that invert the visual area. Okay, that is the reason for that. So if there is any lesion in the optic chiasm, we'll get bitemporal hemianopia. Okay, so we may get left hemianopia of the right eye. That is also possible. Okay, what happens if the nasal hemiretinal fiber, nasal fiber is cut here? Suppose some nasal fiber is cut here. What will happen? This nasal fiber or the fiber here. Okay, so then the nasal fiber crosses. So both this is the nasal fiber, this is nasal fiber. If they are cut, we'll get the bitemporal hemianopia. But if the temporal fiber is cut here, suppose this temporal fiber is damaged here, periphery. This temporal fiber represents the nasal field of vision. So we'll get the left hemianopia of the right eye due to lesion of this temporal hemiretina or temporal fibers. We'll get the nasal field defect. Okay, that will happen. Now I'll go to the optic tract here. Optic tract will get, this is the right optic tract, will get left homonymous hemianopia. So this is the fiber, this is the temporal hemiretina, temporal fiber that represents the nasal field of vision. So this is the right side. We'll get the left field of vision here lost, and we have also this fiber going there. This fiber represents that area, the left area, the temporal field of vision of the left eye will be lost. That is the left homonymous hemianopia in case of right optic tract lesion. This is the lateral geniculate body we just discussed. We have 6 layers. We have for each lateral layer and also the layers for the contralateral fibers. Okay, so we got that. Now we'll go to that the the fiber from the lateral geniculate body that is called the optic radiation or geniculocalcarine fiber. We have two sets of fiber, lower sets of fiber. that goes along the lower part of the lateral ventricle through the temporal lobe of the brain to the visual cortex. Okay, suppose these are the lower fiber. Okay, so lower fiber damage will lead to upper quadrantopia. Upper quadrantopia. These are the suppose this is the lower fiber that will lead to upper quadrantopia. This is the upper fiber. Upper fiber in relationship to the lateral ventricle goes through the parietal lobe of the brain, and in that condition we get the lower quadrantopia, left lower quadrantopia. Okay, we have to remember that this right side is associated with the lesion of the left side. Okay, so left field of vision. Okay, uh, right optic radiation like optic tract. Okay, so these are right, but we have the field field defect on the left side. Okay, that is the left homonymous heminopia. This is called quadrantopia inferior. Inferior means inferior quadrantopia is due to the superior fiber, the optic radiation fiber. That lesion will lead to left inferior quadrantopia. Okay, we have the superior quadrantopia. Why this happen? This is due to the inferior. This is the inferior optic radiation. You get the left superior quadrantopia. Right inferior optic radiation fiber will right to left superior quadrantopia. Right superior optic radiation fiber or geniculocalcan fiber for superior fiber will get the inferior. For the inferior fiber will get the superior. This is the inferior fiber will get superior quadrantopia. Okay, so again try. We have the optic nerve cut will get the total blindness of the same side. This is right optic nerve cut, right eye total blindness. Then this is the optic chiasm cut will get bitemporal hemianopsia. We have the lateral fiber, that is the temporal hemiretina fiber lesion here, that will lead to the nasal field of vision of that side. This side lesion. This is the left hemianopia of the right eye. Okay. Then lateral geniculate. This is the optic tract. If it is cut, right side cut, will get left hemianopia. That means this is the fiber, this is the fiber, this fiber represents the nasal field of vision, like that. And this is the fiber. This fiber it is containing this fiber. This fiber represents the this is the nasal fiber that represents the temporal field of vision of the left side. So like this. And quadrantopia associated with the upper fiber or lower fiber. Superior quadrantopia is due to the damage to the inferior fiber. Inferior fiber passes through the parietal lobe. Superior fiber passes through the inferior fiber passes through the temporal lobe. Superior fiber passes through the parietal lobe. Okay, superior geniculocalcan fiber lesion will lead to inferior quadrantopia. Okay, we got that. Now you go there, here. Now this is cut. What will happen? Total blindness of this eye. This optic nerve is cut. What will happen? The total blindness of this eye. Optic chiasm cut. What will happen? Bitemporal hemianopia. Okay. So like that, if the optic tract is cut on the right side, then we'll have left homonymous hemanopia. That will happen. Okay, we have the quadrantopia upper side, then it will be due to the lesion of the lower geniculocalcan fiber lesion. We have macular sparing Okay, this may happen. This happen due to the lesion very close to the occipital lower visual cortex area. Okay, we got that. Now these are my references, and that's all about